Welcome, welcome. Thanks for joining us for another deep dive.
Great to be here.
Today, we're tackling a really complex and a fascinating topic pulled straight from a listener's detailed revision notes.
Mm-hmm.
Think of this as your high-yield shortcut to truly understanding tuberous sclerosis, especially if you're preparing for something like the MSRA exam.
Absolutely. We've got this comprehensive set of notes here, moving from the absolute basics all the way through management and prognosis.
Right.
Our goal is to unpack this material, highlight the most crucial nuggets, and really help you connect the dots, seeing how all these pieces fit together into the full picture of tuberous sclerosis.
We're going to walk through the definition, the underlying causes, how it typically shows up in people, how it's diagnosed, and what's done about it.
Yep, cover all the bases.
If you're looking for a clear, structured overview rooted directly in this specific source material, you are definitely in the right place. Let's dive in.
Let's do it.
Okay, let's unpack this. Kicking us off, based on these notes, what exactly is tuberous sclerosis? What's the fundamental definition we need to grasp?
Right, so the notes define it as a rare genetic multisystem disorder.
Okay, rare and genetic, multisystem.
Exactly. And the core characteristic is the growth of non-cancerous tumors, technically called hamartomas, in multiple different organs throughout the body.
Hamartomas, got it.
You'll often hear it referred to as Tuberous Sclerosis Complex, or just TSC.
CTSC, yeah.
The notes also mention you might encounter older synonyms like Bournville's disease or epiloia, though those are less common now.
Right, older terms. Okay, multisystem, you said. Which organs are most typically involved, according to this material?
It really can affect many places, but the notes specifically call out the brain, skin, kidneys, heart, lungs, and eyes as commonly involved.
So a wide range. All right, so non-cancerous tumors in multiple organs. What's driving this? What's the underlying cause or the etiology?
This takes us into the genetics and the actual nuts and bolts of the pathophysiology. It's quite interesting. The notes clearly point to mutations in one of two specific genes, TSC1 or TSC2.
TSC1 and TSC2, what do those genes normally do?
Good question. They produce proteins called hamartin and tuberin, respectively.
Hamartin and tuberin.
And when these genes are mutated, the notes explain, it disrupts a really critical cellular signaling pathway called the mTOR pathway.
Ah, the mTOR pathway. This is where it gets really interesting, because normally that pathway helps control cell growth, right?
That's exactly it.
So the mutation leads to too much activity in this pathway.
Precisely. That's the key mechanism highlighted in the notes. The disruption leads to overactivation of the mTOR pathway.
Right.
And that overactivity drives abnormal cell growth and the formation of these hamartomas we talked about across all those different organs.
Wow, okay.
The notes also add an important distinction. Mutations in TSC2 are generally associated with more severe disease compared to TSC1 mutations,
Oh, interesting.
which they note are found in about maybe 10–30% of cases, the TSC1 type.
Fascinating how one pathway can have such widespread effects. Is this always something you inherit from your parents?
Not always, which is another key point from the notes. While it can be inherited in an autosomal dominant pattern.
Meaning a 50% chance if a parent has it.
Exactly. If a parent has it, 50% chance their child will inherit the gene mutation. But the notes state that a large majority, about 75–80% of cases, are actually due to sporadic mutations.
Sporadic, so brand new.
Brand new mutations that occur spontaneously in the individual and weren't present in other parent. De novo mutations, basically.
Okay, so risk factors are either having a family history for the inherited type or simply the chance of that spontaneous new mutation occurring.
Precisely. From the perspective of these notes, those are the core risk factors. Pretty straightforward in that sense.
Switching gears slightly, let's talk about how common this condition is. What does the epidemiology section of the notes tell us?
Looking at the UK numbers provided, the notes estimate the prevalence, that's the total number of people living with it at a given time, is about 1 in 10,000 people.
1 in 10,000.
Okay. The incidence at birth, how many new cases there are per year per population, is actually higher, estimated at 1 in 5,800 births.
Higher incidence than prevalence. Interesting.
Yeah. It affects both genders equally and appears across all ethnic groups. A really crucial point the notes emphasize, and one that comes up repeatedly, is the incredible variability.
Variability, right. We keep hearing that.
Huge variability, not only in which organs are affected, but how severely, and even how the involvement might change as a person gets older.
That variability sounds like a major challenge for diagnosis and management. So how does it typically present? What are the clinical features someone with tuberous sclerosis might show?
The clinical picture is really diverse. because of all those organs involved. The notes break it down nicely by system, which is helpful.
Good. Where do they start?
Let's start with the skin, as this is often one of the earliest and most visible signs, especially in childhood.
Okay, skin signs.
The classic skin lesions include those depigmented ash leaf spots. These are lighter patches of skin.
Ash leaf spots, like the shape of an ash leaf.
Kind of, yeah.
Yeah.
The notes point out they can stand out more clearly under UV light, like a wood's lamp, because they fluoresce.
Ah, useful diagnostic trick. Got it. What else on the skin?
You might see roughened raised patches, often on the lower back, called shagreen patches.
Shagreen,
Yeah.
like the textured leather.
Exactly that texture. The notes also mention forehead plaques as another possible skin finding. Then there are the angiofibromas on the face, sometimes called adenoma sebaceum,
Right, I've heard that term.
which are small, reddish bumps, often forming a butterfly pattern across the nose and cheeks.
That butterfly pattern is quite distinctive, isn't it?
It can be, yeah. And finally, fibrous growths under the nails, known as subungual or ungual fibromata.
Under the nails, okay.
The notes add a careful distinction, though. While you occasionally might see cafe au lait spots.
Those light brown patches.
Yeah, the ones more classic for conditions like neurofibromatosis. The notes explicitly state these are not a diagnostic sign of TS.
That's a really helpful clarification. Don't get sidetracked by those. So skin signs can be key, especially early on. What about neurological features? You mentioned the brain is commonly involved.
Yes, and this is often where some of the most significant challenges arise. The notes highlight developmental delay is very common.
Okay, developmental delay.
Epilepsy is listed as extremely frequent messinating. They mention specific types like infantile spasms, which can be quite serious in babies, and various focal or even generalized tonic-clonic seizures later on.
Seizures are a big part of it then.
A very big part. Intellectual impairment is also common. The notes link these neurological problems directly to those cortical tubers in the brain. The hump navel is there.
Ah, the tubers.
Yeah, noting they often present early, frequently before age 5.
Before 5, wow.
Cognitive and behavioral problems are also common things like learning difficulties, autism spectrum disorders, ADHD, sometimes aggression, anxiety, a whole range.
So a real impact on development and behavior. Brain and skin are clearly central. What about the other organs on that list? Eyes, heart, kidneys, lungs?
Absolutely. The notes cover those too. Let's see. Eyes. You might see retinal hamartomas.
In the eye itself.
Yes, on the retina. Described as dense white areas, sometimes called phacomatal.
Phakomata, okay.
Heart. Cardiac rhabdomyomas are mentioned. These are heart muscle tumors.
Tumors in the heart, that sounds serious.
It can be, but interestingly, the notes point out these may be present in early childhood, but often regress spontaneously over time.
Oh, they can shrink on their own.
Often, yes, which is somewhat reassuring.
Good to know.
Back to the brain for a moment. Beyond the cortical tubers, the notes mention gliomatous changes can occur within brain lesions. And importantly, they list subpendymal nodules, SENs,
Right.
and subpendymal giant cell astrocytomas, SEGAs.
Segas and sagas, more brain lesions.
Yeah, SENs are nodules near the ventricles, and SEGAs are larger tumors that can grow from them. We'll come back to those.
Okay, kidneys.
Renal involvement is common and can include polycystic kidney disease or renal angiomyolipomata, AMLs for short.
AMLs, fat, muscle, blood vessel tumors.
Exactly. And these can potentially cause symptoms like pain, bleeding, or lead to kidney dysfunction over time.
Right, potential for kidney problems.
Right.
And lungs.
Pulmonary involvement can occur, particularly with lymphangioliomyomatosis, or LAM,
Lamb. That's thanks.
causes multiple cysts in the lungs, more
Right.
common in women, and something called multifocal micronodular pneumocyte hyperplasia, or MMPH. Less common, maybe.
Okay, lamb and MMPH in the lungs.
So the notes wrap up this section by reinforcing that while TS can present at any age, sometimes even detected before birth.
Prenatally, wow.
Yeah, but it most commonly becomes apparent in childhood, often with those telltale skin changes and epilepsy before age 5. But it can also remain subtle or latent and only be diagnosed later in adulthood.
So it can hide for a long time.
It can. They also mention the diagnosis is often clinical, based on a combination of these major and minor features, allowing for classification as definite, probable, or possible TS according to set criteria.
That makes sense, given the wide range of presentations. You need criteria. With so many potential symptoms across different systems, what other conditions might mimic tuberous sclerosis? What's in the differential diagnosis based on these notes?
Good question. The notes provide a list of other conditions you'd need to consider, particularly those that also involve both the skin and the nervous system. Makes sense, right?
Yeah, they overlap.
So they list neurofibromatosis, Sturge-Weber syndrome, neurocutaneous melanosis, von Hippel-Lindau syndrome, and multiple endocrine neoplasia type 1, or MEN1.
Okay, a few key syndromes to keep in mind.
It's really about having those other possibilities in mind when you see a patient with a combination of these kinds of signs. Rule them out or consider them.
Got it. So if you're seeing some of these features and tuberous sclerosis is high on your radar, how do you move towards confirming the diagnosis and figuring out the full extent of the disease? What does the investigation section outline?
The notes lay out a pretty clear path for investigation. It starts, as you'd expect, with a thorough clinical evaluation.
History and exam?
It's exactly taking a detailed history, family history too, and doing a physical exam to identify all the potential signs and symptoms we've discussed, really looking for those features. Then, genetic testing is highlighted as a key tool for confirmation, especially when there's a strong suspicion or family history.
Looking for the TSC1 or TSC2 mutation.
Precisely, looking specifically for mutations in those TSC1 or TSC2 genes, though not everyone with clinical TS will have an identifiable mutation with current tech.
Right, okay. And imaging is crucial for seeing what's happening inside, I assume.
Absolutely. Imaging studies are fundamental for assessing the hamartomas in various organs. MRI or CT scans of affected areas, particularly the brain and kidneys, are standard.
Brain and kidneys seem key for imaging.
Definitely. The notes specifically flag brain MRI as necessary to look for tubers, SENs, and those SEGAs we mentioned.
SEGAs again?
And importantly, they state that an urgent brain MRI is needed if a SEGA is suspected.
Why the urgency for SEGA? What's the risk there?
Well, because, as the notes imply later in the prognosis section, SEGAs can grow. If they get big enough, they can potentially block the flow of cerebrospinal fluid within the brain.
Leading to hydrocephalus.
Exactly. Increased pressure in the head, which could be a neurological emergency. So early detection and close monitoring are critical.
Okay, that makes sense. Urgent scan for suspected SEGA. What else?
Other investigations mentioned include fundoscopy, looking at the back of the eye.
For the retinal hamartomas, the facamata.
Yep, exactly. Using that Woods UV lamp for the hypopigmented skin spots, the ash leaf spots.
Yeah, see them glow.
An EEG, if epilepsy is part of the picture, to characterize the seizures. And an ECG to check for cardiac arrhythmias.
Any specific arrhythmias?
With a specific note about Wolff-Parkinson-White syndrome, WPW, being associated sometimes. And then echocardiography, an ultrasound of the heart.
To look for the rhabdomyomas?
Yes, specifically to evaluate for those cardiac rhabdomyomas, even if they often regress. Need a baseline.
Makes sense. What about the kidneys?
For the kidneys, beyond MRI or CT for the AMLs or cysts, the notes recommend yearly checks of renal function blood tests, urine tests, and blood pressure monitoring.
Why yearly?
To screen for kidney dysfunction and hypertension, as those AMLs can sometimes cause problems like bleeding or damage over time.
Right, ongoing monitoring is key. And the lungs?
If there are respiratory symptoms that might suggest LAM, then the notes recommend lung function tests like spirometry, a chest X-ray, and especially high-resolution CT scans, HRCT, of the chest.
HRCT for the lung cysts. Got it.
So, yeah.
Wow, that's quite a comprehensive workup. It really takes a whole-body approach to get a full picture of how tuberous sclerosis is affecting an individual.
It absolutely does. You have to look everywhere.
So once diagnosed, how is the condition managed? What do the notes say?
Well, because it touches so many different systems, the notes really emphasize that management requires a multidisciplinary approach. That's probably the key message for management.
Makes sense. A team effort.
Definitely. Bringing together various specialists, neurologists, dermatologists, nephrologists, cardiologists, pulmonologists, developmental pediatricians, geneticists, maybe psychiatrists, social workers, educators, others to work collaboratively.
A big team.
A big team. The focus of management is primarily on addressing the specific symptoms and complications that arise in that individual.
Tailored to the person.
Exactly. For developmental and behavioral issues, that includes things like behavioral support, tailored schooling plans, and regular developmental assessments.
And family support.
Yes. The note specifically lists supporting the family with social support and advice on benefits as crucial components. It affects the whole family, you know.
So it's not just about the medical issues, but the broader impact. Really holistic.
Exactly. Medically, anti-epileptic medications are the mainstay for managing seizures. Finding the right one or combination can be tricky.
I imagine so. What if the seizures are hard to control?
If the epilepsy proves difficult to control or refractory, as the notes say, then they suggest considering interventions like epilepsy surgery.
Surgery?
Yeah, sometimes removing the specific area of the brain causing seizures, if possible, or vagus nerve stimulation, VNS, which is like a pacemaker for the brain.
VNS, okay. Other treatments.
For lung involvement, for LAM, the notes briefly mention hormone treatments as a possibility, or newer targeted therapies, actually. And surgical intervention might also be necessary for specific problems.
Like what?
Like controlling bleeding from kidney lesions, the AMLs, removing problematic skin lesions if they're bothersome or disfiguring, addressing certain tumors, like removing a growing sega, or managing other renal issues.
So managing specific complications as they arise.
That's a big part of it. And the notes also stress the importance of regular follow-up. Surveillance is key.
How regular?
Annual or sometimes more frequent assessments are needed to monitor epilepsy, neurological status, cardiac health, especially in kids, skin changes, renal function, and AML growth, pulmonary status if relevant, and developmental progress. Keep checking everything.
That highlights the lifelong nature of the condition and the need for ongoing vigilance. Speaking of lifelong, what does the long-term outlook look like? What's the prognosis, and what are the most significant potential complications described in these notes?
The prognosis, as you might expect, given everything we've said about variability, differs significantly from person to person.
Highly variable again.
Hugely variable. Depends heavily on the severity and the specific organs involved. The notes describe it as a lifelong condition, but one that can be managed with appropriate ongoing care. Many people live relatively normal lifespans now.
That's good to hear.
Yeah.
What are the common complications?
Common complications listed include neurological deficits and developmental disabilities, which makes sense given the frequent brain involvement.
Right.
Renal issues like bleeding from AMLs or gradual kidney failure and tumor growth, particularly the SEGAs, are also common complications needing management.
And what about specific, potentially life-threatening complications? Does it affect lifespan?
It can, unfortunately. The notes explicitly mention specific causes of death that can occur. Status epilepticus.
Those prolonged seizures?
Right, which can be dangerous. Bronchial pneumonia, often related to neurological issues, maybe swallowing problems or immobility. And renal failure, stemming from the kidney involvement if it becomes severe.
Okay, so serious risks are there.
They are. Looking at the impact of epilepsy, the notes mention that its severity significantly impacts development, but controlling seizures effectively can lead to better outcomes.
So seizure control is critical for development.
Very important. The prognosis specifically for SEGAs, those giant cell astrocytomas in the brain, is described as excellent, provided they are appropriately monitored.
That regular imaging.
Yes, and surgically removed if they start to grow or cause symptoms like hydrocephalus. Catching them early is key.
Good prognosis if managed well, that's positive.
It is. Genetic counseling and screening are highlighted as important, particularly for individuals with TS who are of reproductive age and for their family members, to understand the risks of inheritance and options.
Makes sense, especially with that 50% risk in the inherited form.
Exactly. Finally, the notes offer a glimpse into the future, mentioning ongoing research into targeted drug therapies.
Oh, like what?
Particularly those that regulate cell growth or target hamartoma growth, specifically drugs called mTOR inhibitors, which target that pathway we discussed right at the start.
Targeting the underlying mechanism.
Precisely. These are becoming more common treatments now for things like SEGAs and AMLs, sometimes avoiding surgery. The notes see these as potential future treatments, though they're already in use. They also briefly note the possibility of prenatal testing in some cases.
mTOR inhibitors, that's a big development. Wow, that really is a comprehensive journey through tuberous sclerosis, drawn directly from these notes. It paints a picture of a condition driven by a specific genetic pathway issue that can manifest in incredibly diverse ways across the body.
Such diverse ways.
Demanding truly multidisciplinary care and lifelong monitoring.
Absolutely. And hopefully, by taking this deep dive, breaking down each section from the notes and seeing how they connect, you now have a much clearer, high-yield understanding of tuberous sclerosis, hitting all those crucial points for revision.
Definitely feels clearer now. It really does underscore how a single underlying genetic glitch can lead to such a spectrum of issues, doesn't it?
It really does.
Which leaves us with something interesting to ponder. What does the sheer degree of variability seen in tuberous sclerosis, even among people with the same gene mutation, tell us about all the other complex genetic and environmental factors that must influence how any genetic disorder actually plays out in a real person?
That's a great question. Modifier genes, environment, lots still to understand there.
Food for thought. And that brings us to the end of this deep dive into the tuberous sclerosis revision notes.
We hope this focus session has been valuable for you and helped solidify your understanding of this complex condition.
We took these notes and really aimed to make the key information stick for you. If you found this helpful or have other topics you'd like us to unpack, please let us know.
We're always looking for suggestions.
And just a reminder, the source material for this deep dive came from revision notes related to the MSRA exam.
For more resources like these, you can check out pastthemsra.com and freeisra.com.
Great resources. Thanks for joining us for this deep dive. We'll be back soon with another one.
See you next time.